Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anees Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about the care of patients with neuroendocrine tumors with Dr. Pamela Kunz. Dr. Kunz is an associate professor of internal medicine and medical oncology at the Yale School of Medicine, where Dr. Chagpar is a professor of surgical oncology.
So, Pamela, maybe we can start off by you telling us a little bit more about yourself and what it is you do.
Sure, happy to start with that. So I am a medical oncologist, and generally that means that we give treatments as part of a big team, a multidisciplinary team that takes care of patients with cancer. Typically, we give things like chemotherapy or immunotherapy. And my area of focus, both in terms of caring for patients and research, is in the field of neuroendocrine tumors.
So let's pick up with that, because while many people may know what a tumor is and may have some idea about neuro, the whole concept of neuroendocrine tumors might be a bit foreign for our audience. So can you tell us a little bit more about what exactly neuroendocrine tumors are?
Sure. So neuroendocrine tumors are a form of cancer. They are actually quite rare and can originate in almost any part of the body. I'm a GI cancer doctor, so many of them originate in the GI tract and in the pancreas and other areas in the abdomen, but they can originate in places like the lungs or outside of the GI tract. And they are rare in the sense that about 7 per 100,000 patients are diagnosed in the United States every year. But many of these neuroendocrine tumors are actually very slow growing compared to other cancers. And therefore, they are more common by prevalence, meaning the number of patients who are alive right now, more common by prevalence than many other cancers like pancreas cancer and stomach cancer combined.
And so why are they called neuroendocrine? If they occur in so many different parts of the body, can you give us a kind of an idea of how they start and what kinds of things fall into this very large bucket called neuroendocrine tumors?
Sure. So neuroendocrine tumors arise from neuroendocrine cells that are actually scattered throughout many of the organs in our body. And they get their name neuroendocrine because about 30 to 40% of these cancers can secrete hormones. That's the study of endocrinology. We study hormones that are secreted. And so, for example, a patient with a pancreatic neuroendocrine tumor may actually have a cancer that secretes insulin. There are other types of hormones that can be secreted. There is a form of a small intestine neuroendocrine tumor that can secrete a hormone called serotonin, and that can cause symptoms such as diarrhea and flushing. So it really requires, again, back to this multidisciplinary team, collaborations between medical oncology, endocrinology, surgery, and other specialties.
And so with these tumors that secrete these hormones, it seems to me that it would be pretty tough for people to really have a clue as to whether they have these tumors. Can you talk a little bit about the risk factors for developing a neuroendocrine tumor? And genetics aside, what are kind of some of the symptoms that people may present with that might give you a clue that they may be having a neuroendocrine tumor?
Sure. So you briefly mentioned genetics. There are some inherited predispositions to getting neuroendocrine tumors. Those are quite rare, less than 10%. Beyond that, we actually don't know what caused these tumors. We do and have noticed that over the last 30 to 40 years, neuroendocrine tumors are increasing in incidence over time. That is likely due to improved diagnostics. We are getting better at recognizing them and diagnosing them. But it also speaks to perhaps some environmental factors that may be causing neuroendocrine tumors. So really important question and an active area of research, but we don't know. In terms of symptoms, oops, go ahead.
No, please. I was going to ask what kinds of environmental things are being postulated to be involved in neuroendocrine tumors. I mean, a lot of people may be wondering, is this one of those that is associated with smoking, with alcohol, with air pollution? Do we have a clue as to what environmental factors?
We don't know yet. I mean, I think as we both know, many cancers can be at increased risk due to things like smoking and alcohol. We have not proven that link yet. So again, something that the field is broadly trying to research more, but we don't know yet.
Okay. And so then you were starting to tell us about kind of signs and symptoms that people might look out for that might be a clue as to whether they may be harboring a neuroendocrine tumor.
Yes. So it really depends on where the cancer starts in terms of what symptoms a patient might experience. So in the GI tract, a patient may experience abdominal pain, bloating, may actually have a bowel blockage. If a patient has a pancreatic neuroendocrine tumor, depending on where it's located, it may block bile ducts, it may cause pain. And some patients may actually have a cancer kind of sneak up on them. The patient may not have many symptoms. And in fact, this is a pretty classic description from many patients where they feel they may have delayed or missed diagnoses. And this, Dr. Chagpar, goes back to something you mentioned earlier, which is because it's rare and some of the symptoms may be non-specific, like GI bloating or a little bit of nausea or a little bit of discomfort, we often can miss these. And so I think raising awareness, such as through programs like this, is really important, and just really patients listening to their body and bringing any new symptoms to their doctor is important.
Yeah. I mean, but it is one of those things that I would think that even from a primary care physician's point of view, with symptoms that are so nonspecific, it might be hard to make the diagnosis. So what, if a patient does have kind of some bloating, they have some abdominal pain, I mean, it could be anything from, what you ate last night to something really a lot more severe. So, at what point should patients and physicians really be thinking seriously about whether this is something more sinister, like a neuroendocrine tumor? And what does the workup entail?
Mm-hmm. Well, one thing I often will tell my patients, and especially patients for whom, maybe they've been through the medical system for a while and we're sort of talking through, well, what would they do in the future to bring symptoms to a doctor's attention? It's really if a symptom is persistent and or increasing in severity. Is it outside of their norm and something that really is just nagging? And I think those are things where patients really know their bodies best. Bring that to your doctor and say, this just feels very different than my normal. It's something that's new, or it's nagging and increasing in frequency or severity. Those are red flags to us as doctors, and I think would be a reason to bring that to medical attention. I will say also, sometimes these types of tumors, because they are so slow growing, are identified incidentally. Maybe a patient goes in for a kidney stone and gets a scan, a CT scan, for example, and maybe they are then found to have a spot in the pancreas or spots in the liver. And after an additional workup, that may in fact prove that they have a neuroendocrine tumor. So sometimes it can be quite difficult.
And so when patients present to their doctor with these nagging symptoms that are outside of what they would consider their norm, what would the workup entail to try to find a neuroendocrine tumor? Does this involve blood work, for example, to see whether they have higher levels than normal of certain hormones? Would this involve scans like you mentioned? Walk us through how exactly the diagnosis is made.
Sure. So oftentimes a primary care doctor might start with just getting basic lab work. So blood counts, liver tests, kidney tests. If a cancer has spread to the liver, sometimes the liver tests can appear abnormal. If patients are having abdominal pain, we might also get a CT scan of the abdomen. And that's really some form of imaging, whether it's a CT scan or MRI, are usually some of our first tests to look inside the abdomen to look for spots in the pancreas, the small intestine, or in the liver. If we identify those spots, the next step is doing a biopsy. And that biopsy is usually done through a minimally invasive approach with our partners in interventional radiology, where they can numb up the skin, insert a needle using imaging to guide where they're putting that needle to sample some of that, some of the spots in the liver or a spot in the pancreas. Sometimes we'll use our gastroenterology colleagues to help us obtain tissue as well. But the gold standard for proving that someone has a neuroendocrine tumor is to get tissue, and then our pathologists will help identify that under the microscope.
And then what happens? So let's suppose somebody is found to have a neuroendocrine tumor. I guess a couple of questions. When we talk about a number of other cancers on this show, very often the management really depends on whether the cancer is localized to a particular area of the body or whether it is metastatic, has spread throughout the body. Is
Correct.
that the same case in neuroendocrine tumors? And if so, what does the staging involve?
Yes, it's exactly the same. And staging refers to where in your body is the cancer. And often for organs in the abdomen or gastrointestinal tract, that staging refers to also the tumor itself. How many, for example, layers of the small intestine does that penetrate? Are there lymph nodes that are involved? And has it spread to faraway places like the liver or the lungs? And if a neuroendocrine tumor is localized, so for example, just confined to the pancreas, then surgery is the primary tool. Surgery would be with curative intent if it's localized. If we believe that a cancer has spread outside of where it started, so again, going back to the pancreas, if a pancreatic neuroendocrine tumor has spread to the liver or other locations, we still need that original biopsy to help guide therapy. But then we think about doing a systemic treatment that goes everywhere with the hope of controlling the cancer.
And so when we think about neuroendocrine tumors, when you originally started talking about neuroendocrine tumors, one of the pleasant things that you said was that, these are slow growing. And what makes us happy about that is that we think, well, in that case, the prognosis must be pretty good. Is that true even for metastatic neuroendocrine tumors?
Yes, and I'll make a clarification. So for the low grade 1 and 2 neuroendocrine tumors, those are slow growing. Patients with metastatic disease may be able to live for years. We think of this more as a chronic cancer. Often the grade 3 or they're also called poorly differentiated neuroendocrine carcinomas. Those are faster growing, and patients may have a worse prognosis because of that.
Okay. Well, we're going to take a short break for a medical minute, but please stay tuned to learn more about the care of patients with neuroendocrine tumors with my guest, Dr. Pam Kunz.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their Center for Gastrointestinal Cancers is committed to detecting pancreatic cancer early and using state-of-the-art technology to treat the condition. Learn more at smilowcancerhospital.org. Breast cancer is one of the most common cancers in women. In Connecticut alone, approximately 3,500 women will be diagnosed with breast cancer this year. But there is hope thanks to earlier detection, non-invasive treatments, and the development of novel therapies to fight breast cancer. Women should schedule a baseline mammogram beginning at age 40 or earlier if they have risk factors associated with the disease. With screening, early detection, and a healthy lifestyle, breast cancer can be defeated. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to make innovative new treatments available to patients. Digital breast tomosynthesis, or 3D mammography, is also transforming breast cancer screening by significantly reducing unnecessary procedures while picking up more cancers. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anise Chagpar, and I'm joined tonight by my guest, Dr. Pam Kunz. We're talking about the care of patients with neuroendocrine tumors in honor of World Neuroendocrine Cancer Day. So before the break, we were talking about the fact that neuroendocrine tumors are rare tumors that often produce hormones, hence the name neuroendocrine, and they can occur in a whole bunch of different places in the body. And one of the things that Dr. Kunz was mentioning right before the break was that many of these, especially the low-grade neuroendocrine tumors, have a really good prognosis. So, Pam, maybe we can start off by you telling us a little bit more about how these are treated. You mentioned that for localized neuroendocrine tumors, such as, neuroendocrine tumors that might be localized to the pancreas, for example, that surgery would play a primary role. How many of these neuroendocrine tumors, what's the breakdown between localized and metastatic? And can you talk a little bit more about what the treatment would involve in terms of metastatic neuroendocrine tumors?
Sure. So there is a huge range of how these cancers break down by whether they're localized or metastatic, and it really varies by where the cancers originate. So it's hard to make a generalization, but I'll give an example. So for patients with rectal neuroendocrine tumors, we are finding that we're diagnosing more and more of these as patients get more and more colonoscopies. And in fact, we're finding these at much earlier stages where they can be found in a small polyp or a small tumor. They can be removed and patients are cured. I think some other sites like pancreas neuroendocrine tumors may more often be discovered when they've already spread or metastatic. So again, it varies based on primary site. And Anise, I think one of the most exciting things about this field, so I went into this field towards the very end of my fellowship now, I don't know, I'll age myself, but well over 15 years ago. And it was a time when very little was known about the epidemiology of neuroendocrine tumors. We had one or two therapies. We didn't have any novel ways to image. And it's been really in that period of time that we've had at least 3 new imaging modalities FDA approved, about 7 FDA approvals for therapies. So it's been a really exciting and very hopeful time for this field.
Can you talk a little bit more about some of those advances? Like when we think about imaging modalities, I think a lot of us just think about CT scans or maybe PET, but we really don't think a lot about other imaging modalities. So can you dive a little bit more into the advances there?
Yes. So one characteristic of neuroendocrine tumors is that they have a special receptor or flag on the surface of the cell called a somatostatin receptor. And one thing we've learned, and in fact knew this many years ago, is that if you in the course of imaging a patient, if you give them an injection of a material that has a protein linked with a low dose of radiation, think of that like a light bulb, and that protein goes to attach to the flag on the surface of the cancer cell, and we take a picture, it lights up where those flags are, where the cancer cells are in the body. So we have developed a new form of imaging that takes advantage of that, and it is in fact a type of PET scan, but it's very specific for neuroendocrine tumors. There are 3 different types of these PET scans that are FDA approved. One of the most common ones is called a gallium-68 dotatate PET CT. And when a patient comes in, they get an injection of a material that has a protein that's linked with a light bulb. They get it injected and it attaches to the surface of that cancer cell on the flag and lights up. It really helps tell us the extent of the cancer in their body. So it's another tool for staging.
How are neuroendocrine tumors treated systemically? So in many different kinds of cancers, we talk about chemotherapy. We may even talk about immunotherapy. Can you talk a little bit more about how neuroendocrine tumors are treated and maybe some of the advances that have happened there as well?
Yes. So the therapies for neuroendocrine tumors really fall into four main categories. The first is something called somatostatin analogs. Listeners may have heard the terms octreotide or lanreotide. These are actually more like hormone treatments, different than male and female hormones, but they affect hormones involved with neuroendocrine tumor growth. It's a once-a-month injection that patients receive intramuscularly, and it can help slow the growth of the cancer. The second bucket are chemotherapies, and we can use IV chemotherapies. There are some pill form of chemotherapies. In fact, a clinical trial that I had the opportunity to lead nationally was using two pill forms of chemotherapy called capecitabine and temozolomide, fondly abbreviated as CAPTEM. And this is used for metastatic pancreatic neuroendocrine tumors. A third category are what we call biologic agents. These are usually in the form of pills, and they target or disrupt a specific tumor growth pathway. There are a number of these that have been FDA approved in the last decade. Two examples are everolimus and sunitinib. And actually, what's really exciting, just 2 weeks ago at the European Society of Clinical Oncology meeting, we found that yet another one in this class called cabozantinib had a positive clinical trial that demonstrated it was effective for pancreas and small intestine neuroendocrine tumors. And then the fourth bucket is actually I'd say an area that I'm most excited about is called radioligand therapy. And this takes advantage of what I mentioned earlier, that special flag, the somatostatin receptor that lives on the surface of the neuroendocrine tumor cell, and actually targets it with a treatment dose of radiation. So you may remember we talked about that imaging, the PET, that can take advantage of that for diagnosis. This is a therapy. And the therapy that's FDA approved was back in 2018 is called lutetium dotatate. So the radioisotope or the form of radiation is lutetium-177. It's attached to a protein that knows to attach directly to that receptor or flag, and it delivers radiation directly to the cancer cell. That field where you can diagnose or image and treat the same target is called theranostics. And actually, there's an FDA approval in prostate cancer for this with a treatment called lutetium PSMA, also called Pluvicto. And I anticipate that in the field of solid tumor oncology, we will see more and more of these radioligand therapies approved.
So that sounds really exciting, right? The idea that you can attach a dose of radiation to a ligand that will specifically target the cancer cells that you're interested in. One would think that the side effects then would be minimal and that the efficacy in treating these cancers would be optimal because, well, you're targeting the treatment directly to the tumor itself. Is that true, or is there a downside?
So there are side effects with every therapy in oncology, but yes, in fact, this therapy, the 177 lutetium dotatate, or Lutathera is the brand name, is actually very well tolerated. So it's a total treatment course, includes 4 doses. Each dose is separated by 2 months. Most patients come back to me saying, "Doc, that was lots easier than I thought it was going to be." So it's about a 6-hour infusion that includes a special form of hydration called an amino acid infusion, and then a 30-minute infusion of the kind of radioactive protein, the radioligand itself. And the most common side effects can be some mild nausea on the day of treatment. We also monitor blood counts. So red blood cells, white blood cells, and platelets can sometimes become low on this treatment, usually not until the very end or towards that 4th dose. And some people can develop some fatigue. There is a rare but serious side effect in less than 2% of patients, where patients can develop more profound effects on their bone marrow called myelodysplastic syndrome. That's a form of bone marrow cancer. very, very rare, and is in fact a side effect of some of our other chemotherapies in oncology, and is something that we would monitor for. But overall, very well tolerated.
And presumably very efficacious as well, because you're targeting exactly the cancer cells. So if that is indeed true, why do we have the 4 buckets? Why don't we just have the one?
That's a good question. Well, what's really interesting, so when this was FDA approved back in 2018, it was very quickly put into the sort of second line of therapy, meaning we often will start patients with octreotide or lanreotide. That was that first bucket I described. This is, in fact, a very effective treatment. So for many patients, and in the clinical trial that led to its approval, patients had on average about 2.5 years of stability, and about 1 in 5 patients had a really significant amount of tumor shrinkage. That was one of our most effective therapies. And there was just a press release, a large clinical trial that Yale contributed to, studying this as the first treatment for patients with neuroendocrine tumors. And that press release said, in fact, that is a positive trial. We will know the exact results of that in January at our American Society of Clinical Oncology GI cancer meeting.
Wow. So, in fact, this may end up becoming first line with the targeted therapy. Is that right?
That's right. It may. And that's often how drug development and studying new drugs goes. We often will test it in later lines of therapy. But just as you said, Anise, if it's proven to be effective and safe, it often moves into earlier lines of therapy.
And so, that's such a happy story, right? Like this idea of, finding out about how these cancer cells work, that there is in fact a flag that you can in fact target, and then developing a therapy for that. Can you talk about other exciting clinical trials that are on the horizon, or do you think that we've kind of, hit the jackpot where we are and this is as far as we go?
Well, as a clinical trialist, I love thinking about, so I'm always going to say there's something to be hopeful about, and there's more to learn and better treatments to develop and safer treatments to develop. So I think building on this idea of theranostics and this Lutathera that we just described with the flag and the target and using the radioligand therapy, I think there are probably ways that we can improve on that. And in fact, we are just bringing a new trial to Yale that is looking at a different type of radiation. So it's a different radioisotope called actinium-225, and it emits a different type of energy particle called an alpha particle. The other therapy we just talked about was a beta particle. We didn't go into the details, but an alpha particle has higher energy and travels a shorter distance. So in theory, it will be more effective and less toxic. And so we are just starting that trial at Yale for patients with GI neuroendocrine tumors after they've received that prior Lutathera. So again, trying to really fine tune and make some of these therapies better.
So why only after patients who have had the previous Lutathera? Why not, do a comparison head to head? It may be that this new alpha particles therapy may in fact be better than the Lutathera.
That is an excellent question, and that is all the kind of strategy of drug development. I think that they will need to prove that it's effective first in a later line of therapy, and then perhaps conduct a head-to-head later.
Dr. Pamela Kunz is an associate professor of internal medicine and medical oncology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next week to learn more about the fight against cancer here on Connecticut Public Radio. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.